2:30 right now, so we're going to get started. Thank you for coming. I think it's a little bit warmer in this room than anybody else, in anywhere else I've been today. It's incredibly cold. Anyways, my name is Sandra Azokar, and thank you. I have one person that likes me. And I'm the executive director of Friends of Medicare. And if you're not familiar with the work that we do, we've been around since 1979 promoting the protection and expansion of public health care in this province. So I'm actually very excited to hear from these two young women who have done a lot of work and are going to be presenting you some of the results of the works that they've done in various things. So I think when it comes to healthcare, and we talk about neoliberalism, I nowhere else can you find more evidence of this reality, I think, than in our healthcare system. And it's really easy for us to be able to gauge that, given the fact that we, for 4 decades, had the same government who went from sometimes being really aggressive in privatization, deregulation, and all the trifecta ideas behind neoliberalism, then to becoming a little bit more smarter because they knew that they didn't have the support of the people and started privatizing by stealth. So as Linda McQuaid said yesterday, public service such as healthcare is enshrined, especially healthcare, is enshrined in the concept of equity, where everyone matters. And neoliberalism thought of you only get what you can afford is what we're seeing in quite a few areas within our healthcare system right now. So our first presenter is actually going to be addressing that issue. Rebecca Graff-McRae is a research manager for the Parkland Institute. She completed her undergraduate and doctoral studies at Queen's University, Belfast, exploring the role of memory and commemoration in post-conflict transition. She has previously worked with the Equality Commission of Northern Ireland and Edmonton City Council, and has held post-doctoral research fellowships at Memorial University Newfoundland and the University of Alberta. I think what she's going to be talking about is private clinics, and again, the individualism that has come from that, the privatization, the deregulation, and talk about what some of those realities have been. Alberta has the not so much fame of being one of the first provinces where we have seen the beginning of private clinics, and then subsequently a proliferation of these types of clinics that are now delivering sometimes essential services and putting up a barrier to accessing healthcare. So I'm not going to talk anymore, and I'm just going to let Rebecca go on with her talk. Thank you.
Sandra, thank you. So clearly great minds thinking alike here, and I always know that Sandra's going to pick up on the best quotes, because last night at Linda McQuaig's talk, I was frantically rewriting my introduction to include the quote that Sandra just referenced. But for any of you who were unlucky enough to miss Linda last night, I'm going to read it in full, and because I thought she really encapsulated what many of us really perceive to be the spirit of Canada's public healthcare system. And she said, Medicare enshrines the principle of equality, and this is the very opposite of the neoliberal agenda, in which you only get what you afford. And referring to economic elites, she said, when it comes to healthcare, they can't buy their way to the front of the line or the front of the door. No wonder they're so angry, she says. So I think that's very much how we perceive, especially when we look to our neighbors to the south. I don't mean that there's a little bit of smugness, but a certain sense of pride in our universal healthcare system and this value of equality, universal access that we put on quite a pedestal. And unfortunately, thanks to the wonders of neoliberalism, this is something that's been under sort of constant erosion. And so today, the private clinics that I'm talking about have actually positioned themselves very deliberately and very carefully right at this boundary between what we consider to be public healthcare and private business. And I'm going to talk today about some of the implications of that for the public good, the public interest. So again, and bear with me with my sense of humor today. First of all, the first tenet of neoliberalism which is to commoditize the public good and to turn citizens into consumers. And we see that certainly in terms of private clinics and in terms of other aspects of healthcare. What we're seeing across Canada manifesting in different guises in recent years. So we see the phenomenon of accessory fees or block fees being charged for so-called additional services, or charging instrument fees, facility fees, private surgical fees, as we've seen proliferate in BC, and membership fees, which are all these different attempts to try to profit from the ill, the injured, and the worried well. And so the research that we have coming out next week on 28th of November, focuses specifically on this phenomenon of private membership clinics. As sort of the epitome of this practice to try to exploit gaps in our public system. Well, let's see here. I'm going to leave some of these slides up for you to have a read through rather than me reading out big block quotes, but I liked this one. All of the wonderful ways that we start to undermine our public healthcare system via neoliberal strategies, and all of the different ways in which we do that. So, and what, of course, the diagnosis, which I skipped right over, we have capitalism. It's unfortunate, right? So I want to talk about private membership clinics, particularly as something that we're seeing into the news politically in the last couple of months as well. And in some ways, they've been portrayed as harmless sort of appendages to our public healthcare system. They're just providing services that where there's gaps, where there's lacks in the system, nothing to see here, folks. In fact, in recent months, investigations by the Globe and Mail in collaboration with the Ontario Health Coalition and investigations by CBC's Kate McNamara have uncovered very serious allegations of systemic wrongdoing at private clinics across the country, and specifically in Alberta. Just a few weeks ago, there was the landmark collaborative health clinic in Calgary closed its doors unexpectedly, literally leaving patients, physicians, and employees standing outside the door with unanswered questions and no recourse. Also, any of you might be aware of the situation involving the Pure North Alternative Health Clinic and the potential conflicts of interest regarding our former Deputy Minister of Health, although he was apparently cleared of any formal conflict of interest in that. So these aren't just harmless sort of add-ons to what we consider to be our public health system, and they actually work in quite insidious ways. So I want to start talking a little bit about the political environment and the political ideology that's enabled these clinics to emerge in Alberta and actually to thrive and remain persistent. So where are we going to start? Where all good discussions of political ideology in Alberta start, with Ralph Klein riding a Trojan horse. Okay. Where's Trevor? He would appreciate that. So I like this one. The retreat of the Alberta government from the healthcare marketplace created opportunities for medical entrepreneurs. The point being here is that starting with Klein in the 90s, the systematic cutbacks to frontline health services, the delisting of particular services from provincial health coverage, all of these things, we picture the blowing up the Calgary General, all created the conditions under which private healthcare had an opportunity to come in, not even through the back door, but right through the front door. Suddenly, our public health services are underfunded and undermined, or simply, under incredible pressures. So, private healthcare has the solution for that, right? Again, we can follow through in terms of Klein's proposals, Bill 11, which eventually became the Alberta Healthcare Protection Act, and allowed the contracting out of certain surgical procedures to private clinics. His proposed third way on healthcare, which caused a federal-provincial showdown. And the sort of PC government's continued turning of a blind eye to out-of-pocket payment for certain diagnostic imaging services as well. So it wasn't just Klein, though, and so much of this goes through to a very pervasive ideology within the former Progressive Conservative Party. So here's one of my favorite quotes from former PC Minister Lyle Oberg. He was also a medical physician, interestingly enough. And I think Lyle here encapsulates this idea that for neoliberal politicians, private healthcare is a growth industry. What you have to remember is that healthcare is politics, and politics is healthcare. Healthcare has huge paybacks. Healthcare is going to be there. People are going to get ill. You can't lose. It's brilliant. So in contrast to Martin's discussion about Jeremy Corbyn this morning, nationalized, you're nationalized, we're going to privatize all the things. And Lyle certainly, Oberg made an attempt at that with various private health ventures, from the West Bank private health clinic debacle all the way to establishing the private public partnership hospital in Vietnam as well. So we see this as in any of the who's who of the former PC regime have connections to lobbying for private healthcare initiatives, sitting on boards of private healthcare organizations, Jim Dinning being a good one associated with the Health Resources Center, lobbied for Bill 11. He had an association with a private health insurance firm called Accure Health. The late Jim Prentice, who sat on the board of the Enlive private membership clinic, which was owned by Coral Holdings, is still owned by Coral, which any of you who are familiar with the Koch family, that's K-O-C-H, it's not Coca-Cola, it's Tea Party. So yeah, that's just a joke there. So all of this sort of came to a head, and it seemed to come to a head in 2012 with the preferential access inquiry, with connections between a private clinic called the Helios Clinic and the McPhail-Forzani Calgary Colon Cancer Screening Center at the University of Calgary around these allegations about jumping the queue, that private clinic patients were given access to faster treatment times, faster diagnostics than patients waiting in the public system. So, and after much ado, those allegations were actually upheld, that the queue jumping did occur, and a number of recommendations were set out, and not very many of them actually implemented. So these are just a number of examples of this privatization strategy, which, as we say, sort of epitomized by the Klein years, but has continued unabated throughout the last iterations of progressive conservative government. Underfund, undermine, and overtake. Cuts to the health budget, bend the cost curve, delist services, and essentially create a sense of crisis and a lack of confidence in our public health system. Wait lists are high. Grandma can't get her knee replaced. People are in pain. People are suffering. And that's true, and that's not to undermine the experiences of people waiting. But it is to question whether the only and most efficient or effective solution is to continue that erosion of our public system and fill the gap with for-profit medicine. And of course, I would argue that's entirely not the case. So when we start to talk specifically about private health clinics, and to clarify specifically, with the report that I'm about to release next week, we looked at one very niche manifestation of these clinics in terms of how they operate, how are they able to straddle the line between public healthcare and private enterprise. They're also known as executive clinics, concierge clinics, or boutique clinics. They're trying to portray a sense of luxury or of appealing to a corporate market. And indeed, many of their clients were corporate clients from a lot of Calgary's energy headquarters as well. So they're deliberately targeting those kinds of executive benefits. Hold on a second. Okay, so essentially what we looked at was clinics that, as I said, operate on that line between public and private healthcare. Their business model is one that sells membership packages for supposedly enhanced services above and beyond your local GP's office. So these memberships are exclusive. They deliberately foreground the fact that they have vastly fewer patients in their practices than your average family doctor, because when they see fewer patients, they have more time and personal attention to give to you and your health concerns. That's the logic behind this. But what it actually means is that they're gatekeepers for those services, and deliberately restricting and rationing that service to people who can pay to get in the door. The other aspect of these clinics is that they sell themselves on a collaborative model. So that means they're blending primary care, your physician, and diagnostic tests with complementary care, which also includes things like chiropractic, physiotherapy, massage therapy, nutritionists, occasionally also psychologists, and some of them also leaning towards alternative treatments in terms of naturopathy and things of that nature. So there's two interesting things about this. And one is that many of those complementary services were ones that were formerly covered under the Alberta Healthcare Insurance Plan, things like chiropractic and physiotherapy, but were cut as cost-saving measures in those delightful times that I spoke of earlier. So now there's an opportunity for them. Physiotherapy is actually, apparently, it's not an optional service. It's essential to your preventative health, but now you'll have to pay for it if you want to access it out of hospital. So again, seeing how that strategy operates. So within this model, any medically necessary services, those that are already covered by the Alberta Healthcare Insurance Plan, are billed by the physicians on that fee-for-service basis to Alberta Healthcare. And any of those additional services are either covered by the patient through their membership fee, through a sort of block fee, or payment a la carte. You can pick and choose what services you want to add on to your package. Or, and sometimes in addition to that, they're charged to third-party insurance plans. If you are lucky enough to have a health spending account with your employer, or Blue Cross, or that sort of third-party insurance, you can, in some cases, deduct your membership fees. So this is sort of at the heart of the contradiction of these clinics, is the split between what's considered medically necessary covered services and what are considered these optional add-ons. So in the research, we found a number of these clinics that had been, up until the time of writing, operating here in Alberta. The most notorious, of course, is the Copeman Health Centre, which has been subject to a number of audits here in Alberta and also in BC. I'm going to talk about the audits process in a few minutes if I get there. Most of these clinics operate almost exclusively on a members-only basis. There are a couple here, one which is called Dominion Medical, which operates mostly as a walk-in clinic, but also offers these executive health assessments in which you can pay upwards of $2,000 to get some kind of a super physical that apparently goes above and beyond your doctor's annual physical. Likewise, Northtown Medical is apparently a family practice that also offers these platinum packages for anyone who really cares about your health. You can pay for the executive treatment there. The rest of these that are listed work on a strictly membership model. So work by the Ontario Health Coalition, when they were doing their research, they actually went through and cold called a number of these clinics and similar ones across Canada, representing themselves as prospective patients and seeking to make appointments without being members. And in almost every case, they were told that, oh gosh, sorry, we're all booked up except for our current members. So clearly, there is, in terms of practice, there's a clear restriction on access within those types of clinics. So again, I've talked about this here already a little bit in terms of the sales pitch that these clinics put forth. And the first, of course, is that they are actually solving a problem within our healthcare system. They're taking people out of the waiting queue and helping them to get faster care, those who can pay for it. But they also try to play on this element of nostalgia, and I've noticed this throughout the number of the clinics' sales material, that somehow they're taking you back to an earlier era when physicians had more time for you, when the waiting room wasn't so crowded, when your doctor really cared and knew your entire medical history, which I think actually strikes quite a nerve with a lot of people because they see the changes that have happened to our primary health system as a result of underfunding and lack of investment from our governments, right? So all of these things translate into less waiting, quicker access, quicker diagnoses for any particular conditions, and funneling those patients back into the public system for treatment for those conditions well ahead of your average person who's been waiting. And what is that going to cost you? Well, across the board, usually an average about $3,500 to $4,500 for a basic membership package. I mean, if you want to get into to the luxury services, a platinum package at the Femme and Home Medical Concierge Clinic can run you up to $8,500 and up, and you're always welcome to add additional boutique diagnostic testing on top of that if you like. So it's certainly not targeted at anyone other than the very wealthy and the executive corporate class. So just for an example, a couple of, hard to see here, but an example of the fee schedules from two different clinics. One of which, this one, Femme and Home Clinic, when I went in undercover to their clinic, they handed me the fee schedule. It was laminated. I was allowed to look at it for 5 minutes, and then I had to hand it back. So some of my fees are furiously scribbled on pieces of napkin. They certainly don't value transparency. So within all of this, we talk about private healthcare as being some kind of cost-saving measure. Oh, that doesn't have to come out of the public health budget. But let's look at the elements of the actual costs here. The membership fees, first and foremost. Then the fee for service for any aspects of medical care that are charged to Alberta Health. Then, oh, I like this one, creative accounting, which was the term used to me as a prospective patient. Don't worry, if you can't cover those membership fees, we can work around that. We can bill it in different ways so that it can go to your insurance company. There's tax deductions on those. So, you know, there's a lot of different ways to make sure those get paid. And then there's hidden costs, and some of these were highlighted specifically by Kate McNamara from CBC, about public resources are used particularly on the diagnostic testing aspect of these clinics, where they outsource a lot of their lab testing to like Calgary Laboratory Services and other partially public services. So freedom of information. The biggest challenge I had with this research was actually learning anything about these clinics. And we can just say that the FOIP process is not the ideal way to obtain anything. I asked for a breakdown of costs associated with private clinics and through the public lab services. And this is what was sent to me. This looks very odd, I'm sure. It looks like a blank chart, doesn't it? That's what it is, yep. So that information, you see in the yellow there, it says S16-1. That's section 16, subsection 1 of the FOIP Act, which says that information is redacted to protect third-party business interests. So other information that I asked for along a similar line, I was told regarding Dynalife, which runs the lab services here in Northern Alberta, that information isn't even available to Alberta Health. It is proprietary. It is owned by Dynalife Corporation. They own that lab's data, even in terms of the costs that we are paying for those lab tests to be run. So consider that for a minute. So where did I get information for the report? And I'm going to wrap up a little bit on this. There were a number of audits that were carried out on 3 prominent clinics that were operating in Alberta. And these were carried out between 2011 and 2013. Despite the name, these weren't actually primarily financial audits. What is meant by that term, as per Alberta Health, is seeing whether these clinics are in compliance with the Canada Health Act. So they used a very, very narrow definition of compliance that had to do with this criteria of universal access, extra billing, or improper billing. Are patients being billed for services that are already covered by the Alberta Healthcare Insurance Plan? And so what did we learn from obtaining these audits reports? Well, we learned some things. The main one was that many of these clinics didn't distinguish between their uninsured services and their insured services, between those which are covered by Alberta Health and those which were these supposedly optional add-ons. This was the quote from the audit report. Preliminary indications are there are concerns with access to insured services, extra billing, and some documentation issues. That there's actually no oversight or regulation of these clinics other than what's afforded to any medical clinic under the College of Physicians and Surgeons. So they were literally, through this compliance review, the audit, going based off of these clinics' written policies around access and billing, and with interviews with their physicians and sales staff. So they also found that no non-member patients were seen in Copeman's Calgary clinic, which was the only audit this was mentioned. But so anyone who actually got to see a physician at Copeman had to pay a membership fee or was the child of a member. And Don Copeman, the founder, said this himself. He said, well, we don't advertise that way. Like, sure, maybe somebody could come in, but we don't advertise that way. Also, they found that there was little or no financial value to any of these extra services. In effect, they can charge what they like for uninsured services, and the normal guidelines for buyers of any service apply, i.e. buyer beware. Like, that's the epitome of the marketplace, though, isn't it? Do your research. Actually, this is useless. The flip side to that as well, recent research shows there's very little medical value to any of these extra services. There's actually, in some cases, a severe risk of harm in terms of over-testing and over-prescribing that arises from this business model. And yet, despite all of these things, the audits found no violations of the Canada Health Act. Some concerns, they said, but no violations. What the audits also didn't find were these allegations that were uncovered by Kate McNamara, specifically in relationship to the Copeman clinics, which was systematic, unnecessary testing, the purging of patients who could no longer pay. There was a memo sent from head office in Vancouver. Don't tell these guys they have a legal right to keep accessing necessary medical services at our clinic. Encourage them to find other ways of paying for that annual membership fee. the creative accounting, and the cost to the public service. We also found in the report that there were some serious flaws in the auditing process itself, that they don't uncover what are the real problems behind these clinics, and that those flaws were known. They were known in BC when they conducted a similar process on Copeman clinics prior to the Alberta one. And yet, what we're left with in terms of a political sea change now, we asked, well, where does the NDP stand on this? And I was to call up a couple of helpful clips from the ghosts of NDP past to tell us what their position explicitly on private clinics and private healthcare in general was. One's a great quote here from Brian Mason, but if you guys want to dig through YouTube. The main point is, as you can expect, they're vehemently against these kinds of practices prior to entering government. And even while in government, they have said the right things, and they've certainly made a number of positive decisions around the reintegration of lab services or canceling the privatization of laundry services, things of that nature. Health Minister Sarah Hoffman has also ordered another audit into the Copeman clinics on the basis of those CBC allegations. And yet, as we said, the audits process doesn't go far enough. And is very much what we saw from the reports, a sort of way of politically kicking the can down the road. Well, we looked into them, we couldn't find anything that was an explicit violation. Guess we can't do an awful lot about it. It certainly isn't a proactive policy choice to defend public health care. So I included a wonderful quote here from Drew Barnes of the now departed Wild Rose Party, but I'll let you guys read that one. So in the meantime, we've recommended very specifically that we need to, for the first place, if we were thinking innovatively, we would ensure that our public health system is properly funded, that it's organized, that methods are put in place to address challenges like bottlenecks and wait lists, and to not leave gaps that can be exploited by for-profit healthcare. But in the absence of that, in the meantime, we need to do something. And what we can do is have greater transparency, greater oversight of these clinics. We need to have centralized collection of information so that we understand how many of these clinics are there, how do they operate, who's funding them, who's enabling them, how are they lobbying government. And that was a big thing that we found in the report as well, was the access that particularly someone like Don Copeman has to the former PC ministers of health to discuss all of these things. So I hope that you guys, if you're interested, will pick up the report when it comes out. It'll be available on the Parkland website from November 28th, and I'm happy to take any questions once we've heard from Larissa. Thanks, everybody.
Thank you so much. It's great when we're very fortunate with Friends of Medicare that we actually get to use this valuable research to further the work that we do. And private clinics is certainly one of those areas that we worked tirelessly on in trying to bring attention to the inequity behind this system and how it has been allowed to proliferate. But now we go to Larissa Stendie. You know, when we elected the NDP government in 2015, I think we've had a certain, as the advocates who've been fighting for a long time, we had an urgency to see a lot of change. We've realized that can't be, you can't change the corporate culture in 2 years. So where is the government going? And I think in a lot of ways, Larissa's work is going to try and make an attempt to explain where this government, based on past experiences in other provinces, can take us. Larissa holds an interdisciplinary Master's of Philosophy and Culture, Environment and Sustainability from SUM Center at the University of Oslo, where her research focused on political ecology and applications of Indigenous consultation and deliberative, oh my God, I can't even say it, but you guys can read it, democracy, some kind of discursive democracy. Before returning to Canada, she coordinated international development projects in West Africa and research for the Lancet Commission on Global Governance and Political Determinants for Health. She has served as conference coordinator and research manager for Parkland Institute and as an energy and climate campaigner for Sierra Club BC. Currently, she's an independent consultant working on research, project management, and public engagement with the Canadian Centre for Policy Alternatives BC on the corporate mapping project, which is an amazing project. BC MLA Anna Molson and the Saanich Inlet Network and BC Sustainable Energy Association. So we're very fortunate to have her here today.
Thank you so much, Sandra. Can you guys hear me okay? Is that working? Thanks so much, Sandra. I'm really grateful to be a frequent guest on Treaty 6 territory here in beautiful and cold Amsquah, Iwaska again. Anyone can correct my Cree, perhaps. There is some vulnerability, obviously, in presenting a report that's still in process. So, but I do think there's a lot of value in inviting your creative and constructive criticism as I go through this. If not in this session, if we don't get to it, please come talk to me. I'm over at that corporate mapping table throughout the breaks, taking your input on the website we're developing for that project. So as Sandra mentioned, when the NDP were elected in 2015, we all hoped and expected that they would provide high quality public services, especially given the historic role the NDP had in the founding of Canadian Medicare. We hoped that they might even work to expand this. But because Alberta hadn't had an NDP government before, many held misconceptions about how governments in other provinces had dealt with financing and healthcare in the past. The Fraser Institute wasted no time in June 2015 of putting out a policy lessons for Alberta's NDP government that looked at Ontario and Saskatchewan's records. And there was a very public back and forth between Ontario's former Premier Bob Rae and Rachel Notley herself. This report specifically looks at NDP governments and in particular in social democracies in general. Using key economic and social indicators as well as archival research, Parkland's director Trevor Harris, who's back here, and I have been working on analyzing and comparing the governing of 4 NDP provinces over the last 30 odd years. This was Ontario under Bob Rae, Manitoba under Mike Harcourt and Manitoba under Gary Doran and Greg Selinger, BC under Mike Harcourt and Glenn Clark, and Saskatchewan under Roy Romano and Lauren Calvert. Given this issue's complexity, this report has been kind of parsed out into several components. We look at a brief history and comparison of these governments, the macroeconomic circumstances that they each faced, the federal-provincial relations on healthcare financing, and how each government dealt directly with healthcare issues, specifically hospitals and workforces, and indirectly looking at social determinants of health. We also explore what was absent in some of these efforts. Beyond what did the NDP do in these places, we also look at evidence from other jurisdictions and considered how other progressive governments have acted elsewhere, should they have chosen to do so, opening lines of inquiry for future reports. Social democracy is based on the notion, as we heard last night, around social, economic, and political equality. To fulfill these aims, governments are dependent upon sufficient revenues with which to equalize and expand the provision of social necessities. In other words, aiming to decommodify the requirements of life that otherwise would need to be purchased in the marketplace. And they see the role of government as alleviating suffering and providing assistance to the most vulnerable in society. However, a new normal emerged during the 80s and 90s in the form of neoliberal capitalist instruments of austerity, leading to these governments to face recessions, inflations, adapting to the free trade agreements, and as plummeting prices for many resource commodities. Deficit paydown was prioritized over public service delivery and infrastructure maintenance by all politicians at a time when countercyclical stimulus spending might have prevented some of the deepening of these harshest impacts. These countervailing pressures made governance ideologically murky and prone to appeals to the sort of mythical, mushy middle, both then and now. So before I get going, while this conference is filled with rousing, very witty presentations, I'm sorry, this probably isn't going to be one of them. Instead, what I'm hoping to do with this is reaffirm some of the data and research in what we've seen manifest over the last 20 years. Oops. Oh no, I gave away one of my only jokes. I promise I'm only gonna show a couple large complex graphs as an overview to this research, but in keeping more with the themes of this conference, I wanna get into a broader discussion of the steady rightward shift embracing neoliberal policies. This is the work that helps reinforce those calls to action that a lot of people are doing. But before I get going, did everybody get enough coffee? Like, do you want to have a stretch and maybe a little leg shake? It's the middle of the afternoon and we're about to look at some graphs, so maybe just work it out a little bit. So to set the stage, as you see up here, Canadians are spending a lot on healthcare. It's estimated there's going to be about $242 billion, that's $6,600 per person in 2017, consuming an ever greater portion of provincial spending and public concern. Healthcare and education drive about 2/3 of provincial health costs, with aging demographics, shifting workforces, expensive pharmaceuticals, technological demands, neglected infrastructure. The health system is facing some serious challenges, but none of these are particularly new. What has changed however, are declines in our overall economy, coupled with eviscerated income streams and reduced federal transfers, such that health costs consume a larger portion of a smaller GDP and revenue pie. This has led to systems-level changes towards streamlining and to lean approaches to public services. There's also a growing acceptance among some frustrated Canadians that private health care is perhaps inevitable, as Rebecca so explained. Well, why? We've talked about this already. Under Prime Minister Margaret Thatcher in the UK and Ronald Reagan in the US, the doctrine of neoconservatism preached free market capitalism, anti-statism, social and moral conservatism, yet retaining the state's coercive functions. However, neoconservatism's harshness made it less appealing, and eventually it gave way to neoliberalism, which also supported privatization, deregulation, and the use of internal markets for governing government services. Insofar as revenue generation, we know neoliberalism emphasized a reformed and shrunken tax structure based on low corporate taxes and regressive consumption taxes to fund any government programs. When Reagan and Thatcher outlined the TINA doctrine, there is no alternative, they really set the narrative for the next 30 years of policy. The logic of neoliberalism, as we've heard already this week, is diametrically opposed to the premise and practice of social democracy. Yet, the hegemony of neoliberal capitalism is best reflected in the actions of leftist governments that ideologically and historically had opposed such notions, but have insidiously shifted the trajectory of politics towards, as Martin described earlier, progressive neoliberalism. Parties of left throughout the West, whether calling them social democratic or labor parties, all but abandoned challenges to these types of capitalism. By the 90s in the US, the Democratic Party of Franklin Delano Roosevelt had become the neoliberal party of Bill Clinton. In the UK, the Labour Party's always tepid socialism similarly gave way to the neoliberalism third way of Tony Blair. It blew onto the world stage via NAFTA and other trade agreements globally, which made labor captive to harsh competitive climates, bereft of many protections for workers. This was the world that greeted the provincial NDP governments of the 90s. Within Canada, under Finance Minister Paul Martin, the federal government also began downloading the costs and control over social programs in the provinces, claiming a focus on the national deficit, when in fact, these measures were actually meant to redesign the very role and structure of government itself. Beyond the billions in cuts in just over a few years, the radical decentralization of block grants fundamentally changed the role of the federal government's long-standing expansion of social programs across Canada. The issue of government finance, revenues, expenditures, debt deficits is not an insignificant one. Upon inspection, however, the fact is the NDP has historically had the best record of any government in Canada in balancing the books. A quick caveat though, although it's widely used, we know there are problems with GDP as a measure, particularly because it doesn't take into account unpaid labor and the hidden economy, which fails to capture a lot of economic activity. That said, what does this table tell us? First, unsurprisingly, the NDP government spent as a percentage of GDP more than non-NDP governments. Secondly, surprising to some, the revenues accrued by NDP governments, particularly in the cases of BC and Ontario, were a smaller percentage than revenues brought in by non-NDP governments. Only in Manitoba was the NDP percent higher, while no difference was really detected in Saskatchewan. Third, in every case, revenues captured by both NDP and non-NDP governments failed to cover expenditures, resulting in government deficits. This kind of begs the question of whether achieving balanced budgets through tax cuts or low taxes is justifiable as an end goal for social democracies. an outcome highly inconsistent with the party's stated commitments to redistributing wealth and resources. As Linda McQuaig said yesterday, we don't need to constrain spending when the wallet is empty. Oh, there's a graph, huh? So, while the amount of spending does not necessarily ensure good healthcare, as the United States proves, there is generally a clear and positive correlation between healthcare outcomes and the money that goes into it. With this in mind, this graph details the amount of total healthcare expenditures in the 4 provinces as percent of GDP. It reveals no clear partisan commonalities regarding healthcare spending. During the NDP's years in Ontario, which is the blue line, and you can see here, it's been an interesting study because you're following these trajectories, and so the orange dots are NDP years. That's the way we sort of tried to delineate this a bit. It's not always easy to see, but just to give you a bit of a sense of it. So anyways, the Ontario blue years, healthcare spending as a percentage of GDP held steady on par with the previous Liberal government, notably at the lower end of spending. Saskatchewan in green experienced a roller coaster ride, up and down and up, rising at the end, but still below when the party came into office, but taking a subsequent nosedive under Brad Wall's Saskatchewan party. British Columbia in purple, spending went down over much of the government's first decade in office, but rose later, though at its peak it was no higher than the following Liberal government. Only in Manitoba did healthcare spending increase as a percent of GDP and show a consistent increase, higher than NDP counterparts elsewhere. Now, given neoliberalism's penchant for privatization, sold as a means of creating efficiencies, but too often a greenfield for profit making, as Rebecca explained, we need to know something of this trajectory of all health spending, specifically so we know how much is public and how much is private. Lowered public spending may make government ledgers look good, but they can make individual family ledgers much worse as they struggle to pay for health services out of pockets or maybe go without. In this graph, what jumps out is a general downwards turn in public percentage of spending. NDP governments in all 4 provinces did not expand or defend the proportion of healthcare as a percent of overall spending. In failing to do so, they have, as one might argue, also opened the door to private healthcare alternatives. As public healthcare spending diminishes, people are forced to pay more, as also Rebecca mentioned, in the private sector for health insurance, user fees, private healthcare clinics, non-covered drugs, residential care facilities, delisted or non-listed services. And hence there's this discrepancy between the 2 graphs we just looked at. Neoliberal models seek to undercut government spending until privatization seems like a rational option. But in every Canadian example that we have, the model fails to deliver both economically and in terms of services, every time. Furthermore, this graph suggests that NDP governments since the 80s have not differed greatly from their Liberal or Conservative counterparts. When seeking to reduce spending, often the first places that governments look are hospitals and beds, as well as the workforces tending them, given these are the largest expenses within the system. The report looks more deeply into this interlock, including labor relations faced by nurses, both registered, licensed practical, as well as occupational and physiotherapists. But here I'm just going to go super briefly into the closures and the case for RNs. Given acute care and teaching hospitals are the costliest part of the entire system, during the cost cutting in the 90s, hospital and bed closures in Canada became the norm. Widespread support for reducing the number of hospitals and beds came from both ends of the political spectrum, although for different reasons. But how many beds is enough? Since the 80s, the appropriate numbers have been believed to have been between 4 and 5 beds per 1,000 people. But as Canadians now face extreme shortages in long-term care, those numbers are changing and we're playing catch-up. Hospital restructuring and cuts also depleted the morale of people trying to work and optimize diminished resources with fewer beds and treating more people while also facing the anxiety of possible job loss. Nurses and therapists often report feeling overworked, underpaid, undervalued, putting in long hours of shift work with neoliberal efficiency measures, often jeopardizing both the safety of workforce and patients. NDP governments have not been simply content to just cut back. However, they have attempted, with mixed results, to expand on community healthcare delivery. In order to be successful, these efforts require a range of more and better trained healthcare professionals, but they have often also tried to use cost controls through job substitution. Manitoba provided a good example, replacing expensive physicians who are often difficult to retain in remote locations with lower-cost health professionals, such as RNs or nurse practitioners, or for meeting more specific needs like occupational and physical therapists. But as you can see, Manitoba has a distinction of maintaining the highest number of RNs, regardless of who was in charge. While this number appears roughly consistent, again, Manitoba's in red near the top there, it does not reveal that fewer nursing graduates were also failing to replace an aging workforce, or that many were part-time. In Ontario, in the blue, the workforce stagnated under the NDP, but the population of the province grew. So while workloads increased, patients' access to nurses decreased. Meanwhile, full-time employment declined and more nurses joined the ranks of the precariously employed under the NDP. In Saskatchewan, the ratio fluctuated modestly. This is largely due to the wellness agenda of being central to the policy of the NDP. And in BC, BC in the 90s spent more than any other province on healthcare per capita, but a disproportionate amount of this went to physicians, while ignoring a lot of infrastructure issues and also employing the second lowest ratio of RNs in the country. Wage freezes, back to work legislation, Ray days, privatization. The NDP made some mistakes in terms of this, and they've all met intense backlash over the last 3 years from unionized healthcare workers, straining traditionally supportive relationships. Attempts to bend the cost curve over the long term via efficiency measures that compromise the quality or accessibility of care or on the backs of the frontline workers is not acceptable under the rubric of social democracies. So from that Fraser Institute report, there was one quote I felt like they got kind of right. Right-wing think tanks, like the Fraser Institute, have repeatedly called for a rolling back of the welfare state, arguing that social programs such as healthcare have become too expensive. As noted by political economist Marjorie Griffin-Cohen, under the rhetoric of pervasive neoliberalism, ultimately the argument, we can't afford these programs, has actually become part of the culture of the nation. In the austere economic circumstances of the 90s, the NDP governments accepted the shrunken space for maneuver that they had inherited. Not only were the governments that we studied fiscally prudent, they too often wore this as a badge of honor. And it's reasonable suggesting that the NDP governments have become gun-shy in the face of relentless criticism from the right that social democratic governments are careless with public money. But let's remember that the Alberta PCs were also attacked for overspending and called on to cut back public services even as our economy was flush with oil money. And our provincial spending was right in the middle of the Canadian pack, particularly for healthcare for the last 20 years. When you're a hammer, everything looks like a nail. So to organizations like Fraser, it doesn't really matter who's governing. And their rhetoric has kind of poisoned the well. And this fits right in line with the societal impacts of the neoliberalism project. Author David Harvey has recognized that the redistributive effects and increased social inequality have in fact been such a persistent feature of neoliberalism as to be regarded as structural to the whole project. Inevitably, this strategy of failing to increase revenues has run up against the pragmatics of good governance. In one example, in Manitoba, the Selinger government in 2013 broke a promise of no new taxes by raising the PST 1%, which ultimately lost them the 2016 election to the PCs, who made a lot of noise about this. No one seemed to notice that all those funds went directly to another important NDP promise that was rebuilding crumbling infrastructure that had long been neglected by previous governments. But in another notable irony, in March of 2017, Brad Wall's Conservative Saskatchewan Party, at the time still a darling of political conservatives, also raised that province's PST by 1% to deal with deficits. Going against that neoliberal orthodoxy was a move that set the stage for his retirement some 5 months later. In short, the poison pill of constantly reduced revenues has become the bane not only of NDP governments, and yet, as Linda also mentioned yesterday, people are not opposed to paying taxes for services that they value. So, when we talk about what that means, social determinants of health come up often when we're dealing with healthcare beyond healthcare. These are essentially the conditions under which we live and work, encompassing housing, employment, and other factors that impact health and equity. It's no surprise that poverty exacerbates health problems, but turning a blind eye to meeting the needs of society's most vulnerable people actually tends to increase costs of emergent and complex care. To their credit, most of these NDP governments enacted many social policies supportive of these aims in keeping with their social democratic values, and a few of these highlighted here. Our collective well-being also advances when governments address these social and economic factors, reducing disparities. Regardless of who's at the helm, it's clear that big changes are necessary in the healthcare system in Canada. And it's not just the overly simple solution of more funding. While recognizing the difficult terrain in which these NDP governments have navigated in recent decades, the fact is that too often these governments have accepted the neoliberal frame in terms of how healthcare should be financed and delivered. By doing so, NDP governments have too often also unintentionally set the stage for harsh neoliberal policies later on, including dramatic cuts to public services, wage freezes, and reduced supports to the poor, as occurred in Ontario when Mike Harris's PCs took office following the Bob Rae's NDP years. The circumstances facing Alberta's NDP upon taking office bear some striking similarities to these cases. In each case, the NDP replaced governments that had been in office long enough to entrench themselves in the bureaucracy and wider political culture. The Alberta NDP also inherited a severe infrastructure debt, as the cases of Saskatchewan and BC. Notley faces myriad economic factors well beyond her control. Rae in Ontario also handled rising interest rates, free trade, and a severe recession, while the Harcourt government in BC faced a commodities downturn. As argued here, the starting point for progressive politics generally, and healthcare specifically, is public finances. Austerity measures and privatization may make the public purse look and the balance sheet look good, but these saved costs are too often passed on to families and individuals. The great irony of neoliberal policies' impacts on average people is that often any tax savings that might have been enjoyed by the reduced input into public coffers are rarely counterbalanced by the requisite increased private out-of-pocket spending on healthcare and education. That said, we've seen some positive course corrections from the Alberta NDP, such as returning the private contracts for laundry and lab work to provincial oversight, restarting the audit process for some of these private for-profit clinics. These are both strong steps taken by the health minister. Also, in terms of fiscal adjustments, the higher personal income tax and corporate income taxes are good steps, as well as broadening the province's carbon tax and minimum wage. Neglected under the PCs, hospitals' infrastructure is aging, mostly given that it was built in the Lougheed era. A pragmatic choice for updating public assets might be to convert some of these small rural hospitals to community care or much-needed long-term care centers, as was done on the Saskatchewan NDP. And wrapping up fairly quickly here, we don't need to compare our constrained Canadian system with our southern neighbors. But instead what we need to do is look to similar countries elsewhere that are dealing in innovative ways with healthcare issues. The unfortunate fact is that all the recommendations we started to look at that have emerged as being best for both cost effectiveness and quality service delivery have been echoed over and over since the 80s, both in Canada and abroad. Future Parkland reports hope to delve into examining the feasibility of some of these other issues, such as a national pharmacare plan, inclusion of dental health, broad service community-based centers offering other modalities such as mental health, rather than focusing solely on expensive acute care and physician gatekeeping, as well as getting a handle on the long-term care crisis. Universal access to healthcare is touted as the core Canadian value. It can be sustainable, and Medicare must evolve. But if we value it, we have to be prepared both to fight for it and to pay taxes for it. That also means vocally supporting social democratic policies that better embody the values of equity and social well-being as non-negotiable parts of the good governance that we deserve. Thank you.
Thank you so much, Larissa. I think it's a good lesson on the fact that if we don't learn from our history, we're doomed to repeat the same mistakes. So hopefully we learn. But now we're going to open up the floor for questions. I don't know where my mic runner. Oh, Oh, there she is. Okay. Oh, there's one in one at the back. So we have, I saw a few hands. We have one here in the front. Be gentle. You guys want to sit over there?
Oh, yeah. Okay, sure.
Then that way people can see you.
Please be gentle. It's a work in progress.
I do have a question.
He does.
Sorry. My question is actually like quite simple. Like we talk about like the underfunding of the system in Alberta, and then like it makes me wonder like, what is the estimate? Like how much money do we need to fund it properly, right? What estimates exist out there to say, okay, this is what we need to solve the issues that currently exist with the healthcare system in the province?
Do you want to go ahead?
I think we maybe both need to tackle that one. But what I would say is it's not as, I think this is sort of the part of the problem is getting into that thinking that there is some magical number that would solve all of the problems. And what we've seen is that it's about where the funding goes to, how it's allocated, how the system is organized as well, right? So I can look to the Canadian Centre for Policy Alternatives in BC just did a report last year on systemic changes within the hospital system, waiting lists, referrals process that completely overhauled the wait times for people waiting on orthopedic surgeries in that province. So they had an entire strategy about how to do this without actually spending any additional funds. It was all about providing efficiencies, and I don't mean cost efficiencies, actual efficiency of where those bottlenecks were in terms of utilizing the resources that were already in those hospitals, like ORs that were sitting idle a third of the time. You have two options. Do you contract them out to private surgical companies who are going to charge those patients 5 or 10 times as much for that surgery? Or do you find a rota system that works in order to utilize those surgeries, those slots, for people waiting on the public list and get them in there around the clock in the most efficient way possible? So instead of thinking about this in terms of we just need to keep adding money and money and money to the pot, or we need to cut back until there's nothing left, it's more about saying where are those blockages happening that are causing those spiraling costs further down the road. If you want to call that like upstream thinking.
I understand that, but like, if we don't have that figure, how do we know the system is underfunded?
It's the symptoms, right? It's like, again, treating the disease. You don't necessarily need more medicine. You maybe need a systemic cure, right? And just to sort of echo what you were saying, it's not as simple as just saying we need more money. Money helps, but again, it's looking at where these opportunities for, as you mentioned, efficiencies can sit. We have lots of other examples. As I mentioned, we started doing some research on the project that I'm doing, looking at other jurisdictions, looking at how the Nordics are managing, or the UK is managing, or Germany or Australia are managing these same questions with a lot greater efficacy and not spending any more money necessarily. So it really has to do with looking, as you said, like the ROTA's example is a good one, pharmacare is a good one, dental is a good one. These things that are included in lots of other places that shift that balance between what is an acute care model, which is more costly when you're dealing with it, than preventative or holistic sort of spaces for our well-being. This feeds into, again, the social democracy or the social determinants of health piece as well. There's all these other advantages to having a reduction in poverty, so that you're not spending a lot of money in emergency rooms when people are just trying to access a GP. Really simple things like this that are systemic cures. They don't have a dollar figure necessarily attached to them. They're things that just need to be modified in the way that we approach this. And it's a problem with having a lack of sort of federal leadership where it's needed, like in something like a pharmacare plan. The provinces can't negotiate that. Pharmacare is the thing that's pushing healthcare costs through the roof right now when we're paying for it individually. But a lot of these other countries, they negotiate. We're one of the only ones in the OECD who don't negotiate large-scale buys of pharmaceuticals. So there's lots of spots where we're just kind of still stuck in this old neoliberal model where, oh, well, the private entities will pick up the slack and we can just buy our way out of this, or individuals will take care of it. Because we get influenced by our neighbors to the south on what's actually possible when we should be looking elsewhere.
I think the point as well, when we're looking at the past, in terms of underfunding, how we knew that was underfunded under the Ralph Klein government, for example, is the hollowing out of very specific services. And mostly those were frontline services, or of looking at those particular health services that aren't currently covered by our public healthcare system, things like mental health services for the majority, and things like that, and drug costs, as Larissa mentioned. So if you can provide adequate funding for those aspects of our healthcare, you actually incur cost savings elsewhere in the system. It's not about adding a bag of money to the center of the pot. It's about ensuring that there's adequate funding for those cost drivers all around.
Point. When you look at things like what we examine in terms of the workforce numbers, when you cut education or health, it hurts both the frontline providers as well as the people receiving the service, right? We see this over and over and over. And yet the administrators who are often kind of making those decisions aren't the ones on the ward. They can say, oh, well, but look, you're functioning as normal, so everything is okay. This hasn't had an adverse effect. Meanwhile, nurses are staying longer, unpaid, or teachers are supervising recess and not being paid. So the frontline people will usually fill that gap because they don't want to watch the kids or the people they're dealing with suffer. It doesn't mean that the efficiencies are working. So it's not always about, that is a case where money would make a difference, but it's more around our systemic thinking about who's making the decisions that impact the average people's experience. So there are other questions, though. So
Thank you. I think there's one at the back there, and then there's two here at the front.
Oh, thank you. Okay. So it's not so much a question, it's more of a public concern. And so to Rebecca, because you highlighted your empty freedom of information chart and the fact that Dynalife is a corporation. So if I have blood tests or urine tests, go to Dynalife, I can't access my own bodily. Is that what that means?
That's not necessarily the case. It means that they have the discretion to allow you to access that or not, right? So they will, I'm sure they release that information to patients, but technically the ownership of that information rests with them as a corporation. And in terms of anything regarding costs, they choose to keep that information in-house. Right, so I'm not necessarily referring to patient information, but let's just say Alberta Health suddenly decided they needed to access lab testing results for 10,000 patients who'd gone through Dynalife for some, I don't know, contamination or something like that. They would request that Dynalife release that information, right? They don't automatically have a right to that information.
Okay.
Right, and I'm not suggesting in any case that Dynalife would refuse to release that to Alberta Health, especially given the deal that's in the works. But
or
what I'm
to
saying
the
is,
individual.
Or to an individual requesting that.
Okay.
What I'm saying in terms of the business information, right, in terms of the money side of those things, even though that is supported by taxpayer dollars through Alberta Health, right, that corporate information in terms of costs and revenues is proprietary to Dynalife.
To Dynalife, okay. Yeah. So then the second part of my question is BC, Larissa, because you've done studies there. It's very convoluted, like I've personally had experience with it. It's a very convoluted system, and then with mental health, which is of course a whole other area of public health, they greatly blur and distract from the issue of the treatment to try to make people feel better, so that it's often the people who are poorest who are getting shuffled between this and that and the other thing. And so they don't get any treatment because they don't know how to use the system. And I think you've touched on that a little bit more, but I'll give the Michael.
But one thing I would say about that is actually one of the best cases for having a universal basic income. You know, the bureaucracy that's involved for poor people to, like the technical, trying to keep on top of all the paperwork and administrative nonsense is actually a really excellent gatekeeper to prevent people from accessing some of that money. So while I hear what you're saying, I don't think it's just mental health, and I don't think it's just BC. I think that a lot of these systems are really designed to make it really difficult to access extra help. And the unfortunate thing is that if we did a better job of integrating this, as I was saying, you know, there's a lot of research in other places looking at community integrated health centers and whatnot. It's unfortunately the flip side, the positive flip side of the kind of boutique concierge stuff that Rebecca's talking about. And there are examples of this even in Canada, where you have sort of you have social workers in with the GP and with the nurse practitioner and with the psychologist, in with the physio and a massage therapist in some of these smaller places. In Saskatchewan, they have a few of these centers that's what happened when they closed the hospitals. And elsewhere in the world, you know, these integrated centers, they make the most sense. If somebody's having a healthcare crisis, they go to their GP right now, and that guy has to try to filter them through into other gatekeeping, into other systems. It's incredibly opaque and not very user-friendly, and we need to do a better job of actually servicing the people who really need to access those services.
And if I can add super quickly, I can also say that there are private businesses where you can pay a consulting fee for someone to navigate that confusing labyrinth of medical offices for you.
Yeah, advocates are really an important part of that core piece. You know, when you do have a healthcare advocate or a welfare advocate or whatnot, and that would be ideally part of that.
There's a lot of private consultants now. Anyways, unfortunately, we have time for just one more question, and this gentleman here in the front has had his hand up. That gentleman right there. Yeah, thank you.
So we have a public system, and every time the conservatives, they want to, you know, break it down and bring in more private care, they always say, well, the system's already, we can't hear him.
Okay, come. Let me pass the mic down. Saves your voice from yelling.
So right now we have a public system, and every time there's an initiative by the right wing to bring in more, you know, like that health resources group or something, they say, well, the system's already privatized. They'll say 30% or 40% or some number like that. And whenever I hear that, what does that mean? How much of it is private? How much of it is considered public? What are some of those things?
Yeah.
Well, in those two graphs that I showed you right at the beginning, the one that sort of showed this sort of evolution and the one that was sort of steady, par for the course, that's sort of what that's describing, is that while healthcare expenditures are going up over in GDP, the percentage that's actually public is sort of in a slower incline, right? And that's because the gap is being made up by things that are coming out of your pocket. That's, again, your drug costs. That's anytime you access dental or optometry, or all the things that are delisted or off acute physician-led healthcare or emergent care. So it's a big, wide list, and often, like, again, pharmaceuticals is a big piece of that.
The numbers from CIHI, which is Canadian Institute for Health Information, usually has split that 70-30 public to private, in which they mean that 70% of health expenditures in Canada come from some publicly administered pot, if you can put it that way, either from federal health transfers or provincial health insurance plans, whereas that 30% that comes out of pocket, as Larissa mentions, or through your private insurance plan, your dental, your optometry, your pharmacy, and those types of costs. So it's 70-30. It has been for probably the last 15 or 20 years.
But the wedge is sort of expanding as things like pharmacare becomes more expensive, or pharmaceuticals, I should say.
Yeah.
Anyone else? I guess that's...
That's a, if it's a really short question, then yes, but has to be short.
It's not a question, it's more of a suggestion. I would really like this information to be out in Alberta. Has anybody ever said, we need to have somebody from dealing with medical besides the government on the radio or in our paper or in our communities on a weekly basis? Because I'm really tired of hearing the GDP, the GDP, the GDP. I want to hear about people's health. I want to hear about the happiness thing that they keep track of in Scandinavian countries.
They do that everywhere.
Yeah, they keep track
Actually,
of it
Mark
here, too.
Anielski is like, Edmonton boy is one of the main guys.
And actually, that's a great segue because we're not supposed to make announcements, but we, Friends of Medicare is actually going to be using a lot of that work that Rebecca has put out and that Larissa puts out as well in framing that conversation in the upcoming years. So you'll be seeing a lot more talk about what you heard tonight as well. If you want to hear more about pharmacare, join us on November 22nd at the seniors the Lion Seniors Center, and you'll be able to hear more about how that can make life better for a lot of Canadians that can't afford medication. So those two things. But with that, I want to thank you for your attention, and I definitely want to thank our presenters for such informative conversation today.